Good evening. I'm James Wiseman from the University of Maryland, Baltimore, and I'll be presenting our work tonight on traumatic cerebrovenous sinus thrombosis in patients with blunt traumatic brain injury. We have no relevant disclosures to make. Cerebral venous sinus thrombosis is a described complication of traumatic brain injury. Best estimates indicate that tCVST occurs in approximately 4% of all TBI patients, suggesting that it is a relatively rare event. There is a known association between skull fractures and sinus thrombosis, with rates approaching 40% in the case of temporal bone fractures. Less is known of the consequences of traumatic CVST. Venous outflow obstruction could contribute to intracranial hypertension, worsening secondary injury. There's a known association with venous strokes, and thrombosis might contribute to the interval progression of intracranial hemorrhages. Given the seriousness of these consequences, it is important that thrombosis be identified when present. We hypothesized that specific fracture patterns can inform screening priorities in patients presenting with blunt TBI. This was a retrospective cohort study performed with data from a level 1 trauma center over a 10-year interval. All patients admitted with at least one skull fracture from a blunt mechanism met inclusion criteria. Patients with a penetrating mechanism were excluded. 406 patients were ultimately included in the analysis, of which 85 were diagnosed with tCVST for a total rate of 26.5%. On univariate analysis, patients with frontal bone, temporal bone, or occipital bone fractures were significantly more likely to harbor tCVST than those without. On multivariate analysis, the presence of a temporal bone fracture increased the odds of tCVST nearly 2.5-fold. The highest increase in odds occurred in the presence of combined temporal and occipital bone fractures, which increased the odds of tCVST nearly 4 times. Interestingly, frontal bone fractures appeared to be protective. We will discuss this in a moment. In conclusion, our data support the reports of dramatically increased rates of tCVST in patients with skull fractures from blunt mechanisms. In the interest of determining which of these patients warrant specific screening for sinus thrombosis, the independent predictors in this population were male sex, admission GCS less than 13, and temporal bone fractures, with combined temporal and occipital bone fractures conferring the highest odds. Moreover, we detected signals of systemic underscreening, as only 54% of the patients in our study underwent CTV, with the lowest rate of CTV occurring in those patients with frontal bone fractures. Future direction should define more clearly the clinical consequences of tCVST, clarify the need for and best treatment modality, as well as explore the prognostic and functional implications of this diagnosis.